Cardiovascular pathology, cardiomyopathies. All right, so for the cardiomyopathies, these are very, very important for you to know. This is just chronic disease of the heart muscle, okay? There's separate forms of cardiomyopathies that you have to understand, and it's a very high yield, okay? So starting right off, we're gonna have dilated cardiomyopathy. This is the first type that you have to understand. Okay, what they love to ask is what mutations, what gene mutations are a part of this, what's going on. So for a dilated cardiomyopathy, you have to memorize that it's due to mutation of the TTN gene, okay? And the TTN gene encodes the sarcomeric protein titin, okay? So it's due to sarcomeric protein titin, and it's a mutation of the TTN gene. First thing that you have to know. Now, there's other things that can cause dilated cardiomyopathy that's not due to the fact that it's familial, like the TTN gene. It could be drugs like alcohol, cocaine. Doxorubicin is one of those that we've covered already. And then infections can cause it, like Coxsackie-B virus and Chagas disease, which you'll learn later on in your micro section. All right. What are the findings for dilated cardiomyopathy? So for dilated cardiomyopathy, once again, it can lead into heart failure. And we'll talk about heart failure later on and what that means. But the finding that really, really matters is S3, okay? So S3, although it is present in other types of situations, but they love to talk about it in presence with dilated cardiomyopathy, okay? The sound of the S3 is very, very, very associated with dilated cardiomyopathy. You have to remember that. S3 is for dilated cardiomyopathy, and when we get to hypertrophic cardiomyopathy, it's highly associated with S4, okay? So S3 is dilated. And there's a lot that goes into this, okay? But what I will say is that this leads to systolic dysfunction, okay? And that's kind of the best way that I can describe this. When you have dilated cardiomyopathy, it means that your heart, your left ventricle, has dilated so much that it has no ability to squeeze anymore, okay? So you can't pump out the blood as well as you used to. And that's why they call it systolic dysfunction, because during systole is when we contract and we don't have that large contraction anymore because that muscle has become so thin, right? It's become so dilated, okay? And the reason behind that dilation is because we have eccentric hypertrophy, okay? And eccentric hypertrophy just means that we have the addition of sarcomeres, so the myocardial muscle is added in series, okay? So they're added right next to each other, okay? So they're added like from end to end, and they make it larger and larger and more dilated, okay? So you have longer myocytes with no wall thickness increase. Does that make sense? I hope that's covered. And the reason this occurs is because we have volume overload. Okay, so now let me walk you through that. Volume overload is one of the main causes of this, right? So we already talked about the familial cause with the TTN gene. That's the most common cause with the mutation of TTN gene encoding the sarcomeric protein titin. We talked about infection, alcohol, and all others. Now, what happens if we have volume overload? So for example, if we have an inability, okay, so let's say aortic regurg, for example. For aortic regurg, we have blood that's constantly staying within the left ventricle that's not being shot out. So that increases the amount of total blood that's in my left ventricle that I have to be pushing out, okay? And since that occurs, it continuously leads to eccentric hypertrophy, where the cells, okay, the muscle cells, the myocytes become longer, okay? But there's no wall thickness increase, right? And that's all due to the fact that there's volume overload. Okay, so what we're going to see is that we're going to have an increase in left ventricular end diastolic pressure, right? Because at the end of diastole, right, after we've relaxed, we still have a bunch of blood in there that we didn't shoot out, right, at systole. We have an increase in right atrial pressure because we can't push that blood through because there's a lot of blood ahead of us. And we have a decrease in cardiac output, right? Because we're not able to contract well enough. We have systolic dysfunction. Okay, so once again, overall, we have to understand TTN gene mutation with sarcomeric protein titin, most commonly for familial. You're going to see it, findings of heart failure and S3. The S3 is very important. And you're going to have systolic dysfunction. Okay, it leads to systolic dysfunction. I can't squeeze well enough. I can't get the blood out. Okay, you're going to have eccentric hypertrophy where the myocytes attach from end to end, but they don't become thicker, right? The sarcomeres are added in series rather than in parallel. And it's due to the fact that we have volume overload, okay? And one thing that's associated with dilated cardiomyopathy is stress cardiomyopathy. It's also called Takotsubo cardiomyopathy, and it's known as broken heart syndrome. So patients that are very, very sad or in times of extreme stress, they're going to have increased levels of sympathetic stimulation, like catecholamines floating around, and it can cause the apical ballooning of the ventricle, okay? Now that's all for dilated cardiomyopathy. Moving on to hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, once again, it's usually familial as the other ones. It's autosomal dominant, and it involves sarcomeric proteins, but it's myosin binding protein C and beta myosin heavy chain. You have to know those, okay? So the first one was dilated, which involved the sarcomeric protein titin. This one, hypertrophic, is myosin binding protein C and beta myosin heavy chain. Okay, so those are the sarcomeric proteins that are affected. You have to know that. And the findings are usually going to be S4. I already told you about that. Compare and contrast to dilated is going to be S3, hypertrophic is going to be S4. 3 comes before 4, just how D comes before H in the alphabet. So dilated is associated with S3, hypertrophic is associated with S4. All right, now this is opposite. This is due to diastolic dysfunction, okay? So this diastolic dysfunction ensues after we have hypertrophic cardiomyopathy. We can't relax anymore, okay? So we're constantly strong, okay? We're constantly pumping. So this is due to the fact that we have concentric hypertrophy because the sarcomeres are added in parallel, okay? So now we have an increase in wall thickness, right? So that ventricular wall becomes very, very thick due to concentric hypertrophy where the sarcomeres are added in parallel, compared to dilated where we have eccentric hypertrophy where the sarcomeres are added in series and there's no wall thickness, whereas hypertrophic has increased wall thickness. Now, the reason behind that, it's due to an increase in afterload. Okay, so increase in pressure in the ventricles because of mainly hypertension or aortic stenosis. Okay, so we already talked about how dilated is due to volume overload. This one is due to increased afterload, with hypertension and aortic stenosis as being the common causes. Okay, now what you have to know specifically for this is that young athletes that have sudden death randomly, okay, so if you see a young athlete in the vignette, okay, and they come in and they have sudden death, a syncopal episode during exercise, and that might lead to sudden death, they've been passing out during exercise, the patient mainly has hypertrophic cardiomyopathy due to the myosin binding protein C or the beta myosin heavy chain sarcomeric protein mutation. Okay, that is a question. You might be like, okay, who cares, Nate? Like, why are you bringing it up? It's a question that they love to ask. They ask it all the time. Okay, and I'm sure you've kind of seen it right now, right? With it's all over social media over the past couple of years since COVID has been a thing and the COVID vaccine. People have been relating sudden deaths in young athletes due to taking the COVID-19 vaccine. However, it's usually most of the time, now I'm not saying it's all the time this, but most of the time it's actually this. They have a previous hypertrophic cardiomyopathy which they did not know about, a gene mutation that they did not know about, okay? So keep that in mind. That's something that they always ask about in the vignettes. All right, lastly, hypertrophic cardiomyopathy, okay, is classified as hypertrophic obstructive cardiomyopathy when the left ventricular outflow tract is obstructive, okay? So very easy. And they love to ask about this obstruction. How does it become hypertrophic obstructive cardiomyopathy? The way that it works is that since we have asymmetric septal hypertrophy, so our septum, our ventricular septum actually thickens more than every other aspect of the ventricle. Since that thickens up much more, we will get a anterior motion of the mitral valve, which blocks the outflow of blood through the aorta, okay, during systole. So during contraction, the mitral valve moves anteriorly and it blocks the outflow tract, causing hypertrophic obstructive cardiomyopathy due to the fact that there's septal hypertrophy, okay? That's why the obstruction occurs. Know that. It's a question. They love to ask about it, okay? Very important. Lastly is our restrictive or infiltrative cardiomyopathy. I've only seen them use restrictive. Restrictive, they're going to ask a couple questions on it. All this is just the inability for the heart to relax. So somewhat similar to hypertrophic, but different because we don't have left ventricular thickening more so. It's due to kind of the whole entire heart is kind of restricted, okay? The causes that they like to ask about is amyloidosis. So we already talked about amyloidosis in previous videos, but it's due to abnormal accumulation of the transthretin. Okay, so transthretin is also known as ATTR, right? So that's transthretin accumulation can cause restrictive cardiomyopathy in accordance with amyloidosis. And then hemochromatosis can also lead to restrictive cardiomyopathy. And, we'll see that later on. I'll talk about it in the GI tract, but hemochromatosis is usually going to be seen with skin pigmentation, hyperpigmentation, hepatomegaly, and then they'll get, once again, this restrictive cardiomyopathy, okay? Overall, Loeffler endocarditis is probably the last thing that you need to know, and it's just associated with histology showing eosinophilic infiltrates in the myocardium. But honestly, relatively low yield. I wouldn't worry too much about restrictive cardiomyopathy except for the two things, hemochromatosis and amyloidosis.